Welcome to Voice for Infection Prevention, where we explore the latest developments, challenges, and insights in the field of infection prevention and control. With a passion for promoting patient safety and healthcare excellence, we're excited to bring you engaging discussions with experts, leaders, and innovators in the field. So whether you're a seasoned professional or just beginning your journey in infection prevention, welcome to the conversation. This is Voice for Infection Prevention.
Welcome back to Voice for Infection Prevention. I'm your host, Jacob Hutcherson. Today we're honored to have Brenna Doran join us on the show. Brenna wears many hats, currently serving as Assistant Director of Hospital Epidemiology and Infection Prevention at the University of California, San Francisco. With a diverse background spanning over 11 years as a hospital epidemiologist, 19 years as a college professor in biological sciences, 8 years as a clinical microbiologist, and 2 years as a certified career and wellness coach, Brenna brings a wealth of experience and expertise to the table. In this episode, we're excited to delve into Brenna's multifaceted career and tap into her passion for infection prevention. From her extensive experience in various healthcare and educational roles to her dedication to professional development and volunteer work, Brenna is a driving force in advancing the field. Join us as we explore her insights on crucial topics in infection prevention. Without further delay, let's dive into our conversation with Brenna Doran and gain invaluable perspectives on navigating the dynamic landscape of infection prevention.
This episode is sponsored by Clutch Recruitment, the leading recruiting firm in the country, recruiting exclusively within infection prevention and control.
How did you find your way into infection prevention initially? And then what piqued your interest in the field?
Now, that's a great question. So I graduated in 2003 with a bachelor's degree in biology, and I was fortunate to get my first position as a clinical microbiologist at Phoenix Children's Hospital. And I was in that role for a total of about 8.5, 9 years. But about 5 years into it, I really found myself getting really interested in what was happening to the patients that we kept seeing. Like, we'd see clusters of infections, or we'd see the respiratory seasons kind of ebb and flow. And really just got interested, what's happening to these patients? What's happening at the community level? And then in 2009, we had influenza H1N1. And that was a really interesting time for everybody in healthcare. And I saw some just crazy stuff, like people walking around in N95 masks. People were afraid that their children, might have been exposed to H1N1. And so we had hours-long waits in the ED. Patients who are asymptomatic just being tested and, running all of these viral cultures and all these smears to see what these patients had. And then really seeing, which patients had actual signs and symptoms, who had infectious or really active H1N1 and all the other stray respiratory viruses that they had. And so kind of experiencing that not only as a clinical microbiologist, but also kind of experience that as a healthcare worker in a very different kind of way. So fortunate for me, in that spring, so spring of 2010, they hired a new IP at my hospital, and he was not a nurse. And so up until that point, I just made this assumption that all infection preventionists were nurse. But this particular gentleman had a bachelor's of science degree in biology, just like me. And so I really got a chance to kind of talk to him and learn about how he took his career, his degree in biology, non-nurse, what got him into infection prevention, and really started asking him questions from my biology perspective. And then hearing him not only respond to me back from that microbiology perspective, but being able to give me that IP lens as well. And so I got really interested again in the epidemiology of these infections that I had been working on. And at the time, I already had my master's degree, and I was looking at doing a doctorate degree. So I decided to do a doctorate degree in public health epidemiology. And because I was at my own hospital, and I think I was energetic and passionate, so they were open to allowing me to volunteer in the IP department. So I did that for a bit over a year. And so I got to do things like hand hygiene. I created a hand hygiene program and brought some observations to their awareness, changed some policies, learned how to do some surveillance, and so really got some hands-on practice and opportunity to talk through some of these cases with an amazing group of IPs. So that's really kind of what sparked it and set it afire.
Okay. So a couple of questions then I want to pull from that. Number one, I want to make sure I understood this correctly. You went for your PhD with some sort of focus in epidemiology before you ever had a true infection prevention epidemiology position.
Yes.
Okay. So you're one of the more, I've talked to a lot of a lot of people and looked at a lot of resumes. I feel like it's very rare to have that much education in the field, having not worked in it. So what all went into that decision? Obviously you're interested in it, and maybe there's a philosophical reason for this as to kind of just why you would go that. But it's interesting to me that, it feels like a fair risk. To go and to educate yourself in an area that you haven't particularly worked in. It feels like it's a financial investment potentially, unless the hospital's paying for it. So I guess what all went into that decision to really kind of dive all in and go for the next level of education?
No, that's a great question. I think to answer that, I'd have to go back a little bit. So when I was in high school, I found out my maternal uncle had AIDS. And so I kind of went through that experience with him, and he passed away soon after I graduated from high school. Going through that experience with him really kind of changed my career trajectory. Originally, I wanted to go into law, and I found that I was more knowledgeable than the people that came to our school, and told us about HIV and AIDS and the diseases. And so kind of because of that, I wanted to really get into, vector vaccine research. I really saw myself pursuing that doctorate degree. Life happens, as it does to all of us. And I was in the process of starting a PhD at Arizona State in science education. But because of some personal events, that's something I had to take a pause on. So going and getting a doctorate degree was always a goal, a dream of mine. I also had been teaching at the community college level for approximately 6 or 7 years at this point, and I really enjoy teaching college. And there is a natural ceiling, if you will, both academically and professionally, if you don't have a doctorate degree. And so kind of knowing that I wanted to pursue a doctorate, knowing that I've been a clinical microbiologist, knowing how much I love epidemiology and teaching, I reasoned that the best way to move forward would be to get the doctorate, knowing that I would use it in some way, shape, or another, and also ensuring that there was no glass ceiling for me. So I didn't want to be told no. So I'm qualified for really any job, anywhere, including education, which I still teach.
Now, so my next question, there seems to be a smooth transition or somewhat smooth transition between microbiology and infection prevention. So I'm curious, when it comes to like a day-to-day work, especially being a microbiologist in a hospital, how much different or how big was that transition? Was it a steep learning curve? Was it what you were expecting, or was it not? Kind of what surprises were there? And then just how much different is it? Is it a fair career path for all microbiologists, or was it more work than you were anticipating?
Yeah, that's a lot of really good questions. I'm going to do my best to take them stepwise and maybe let me know the ones I miss. So
Sure.
I would say that it was a vertical learning curve. And so I was a bench microbiologist, meaning I actually grew up specimens, grew up pathogens at the bench. So I went from, really specializing in virology, so growing viruses and cell cultures, setting up, slides, doing that kind of work, to stepping outside of that laboratory-based bench space into really more of an office space. So the work environment, vertical curve, how I approached it, vertical curve, and also I had a very deep understanding of how to identify pathogens, and I understood where I'd find them in the quantity, and I understood what was significant and what wasn't. But what I missed was the pathophysiology. So I really needed to focus on how these pathogens that I know so well, how do they cause disease? And how is that pathophysiology process different in different patient populations? So I had kind of the fundamental understanding of epidemiology. I understood the pathogens, but that true epidemiological piece, taking a pathogen from an individual and taking it to a population level, is something I didn't understand. And even though I worked in a hospital, I worked in a pediatric hospital, I had an awareness of what different clinical healthcare workers did, like a very just high level awareness, but it's very different than actually shadowing and being in that space with healthcare workers. So I would say very much night and day. In addition, I would say that really volunteering in the IP department was paramount for me, because if you're in a lab working a bench, how can you conceptualize what being an active IP would look like? Are they sitting at their computer all day? Are they walking around? Like, what is it that they do? And so I think having, again, the opportunity to volunteer in the department, seeing how they go about their daily work, how they balance rounding, time, at the computer, and then also hearing them talk out that pathophysiology piece, helping them tweeze apart medical records and saying, okay, well, this is related to that, and this is related to that. So really just understanding that overarching process was really important to me. I will say I'm probably a little bit more of an atypical IP. Even though I'm in a leadership position, I really like to see myself as a working IP. And what I mean by that is I regularly like to round. I like to Gemba in various units. I really like to still keep my hand in, microbiology and pathophysiology. I like to remain current on the diagnostic testing methodologies. So much evolution and practices have occurred in the last 10 years since I've been out of the field. So I like to keep my hand in it, because I think it's really important for me to have an understanding of, again, that core knowledge base that I have and how it ultimately translates into what I do now.
I want to hone in on the volunteering piece, because this is something that I've heard a few times now with different people. What did that look like? So when you decided, yeah, I want to help here, who did you confront? Did you just ask and it was a quick yes? Did you have to convince them to do it? Kind of what did that look like? And then part two of this question is, were you doing this in addition to your full-time work as a microbiologist? And if so, how many hours? What did the schedule look like? I just want to hear the whole process for getting into that and kind of how you pulled it off.
No, that's a great question, because I actually used my experience to create opportunities for others, so that play it forward. So I was the first one who'd ever asked to volunteer or spend time in the IP program. And so there wasn't currently a process or a program for that to occur. And so really I'm pretty social. And so I like making friends. And so I had mentioned, that there was that new IP that had the bachelor's degree in biology. And so he and I would, talk regularly. We went to lunch. I learned more about the program, what they did. And I asked him if it would be possible just to come into the IP program, the department periodically, and just do some shadowing so I can glean a better understanding of what it is they do. Because at this time I was considering a doctorate degree, but to your point, I don't want to go do a doctorate degree to support a field I haven't gone into yet, unless I could really see and visualize myself doing the role. And so, I knew the other IPs, so I went and had lunch with them, kind of said, hey, this is what I'd like to do. I know it's a very atypical task, or ask, is there some way that I could spend time in the department that would be value added to you? So I think what was really important is I wasn't just there asking them to give me their time, but I really wanted to come up with like a mutually agreeable arrangement where I was able to take some work off of them and help support the department. So it really started off with, a couple days a week, couple hours after a shift, before a shift, doing some hand hygiene observations, looking at some policies. And then it kind of evolved into me spending a couple days a week there and more full-time days. And I did that in tandem with working as a microbiologist, but also I had started my doctorate degree at that same time. So I was juggling all three. And, kind of into that, again, those shorter bursts, multiple days was really helpful, because that's back when we used to look at chest x-rays for VAEs. So there was a lot of, again, knowledge that I had to assimilate. And then we were doing, skip practices for SSIs. So, where do I go on a chart to see whether or not they use clippers? Where do I go on the chart to find out what antibiotic they gave? And what was beautiful about that process is I may not know anything about clippers, but I did know about antibiotics because I was a clinical microbiologist. So in the process of volunteering, I was really exposed to things that I knew. And I was able to really make those connections for core knowledge that I had. And then how does this knowledge that I have, how does it apply, for IP, or how does it apply in a clinical perspective? And then the up and downstream consequences of that. So that was really a beautiful opportunity. And so I did that for a bit over a year. And then I decided I wanted to be a full-time IP. So I started applying for positions. Now, at the time, this is in Arizona. and the field was still predominantly nurses. And so what I found out pretty quickly is that, if there was a larger hospital, so a team of 2 or 3, maybe they'd have an epidemiologist, but really, unless it was a bigger team, they would only have nurses because they really wanted that clinical expertise. And so
Right.
after about 6 months of applying for a role in Arizona, really all the hospital systems that were large enough for somebody like me to step into, they didn't have any openings. So at that point, I actually started looking outside of Arizona. So I started interviewing California, Washington, Oregon.
Wow. Okay. So you said okay, how long did you volunteer?
But over a year.
A little over a year. Okay. And then on average, how many hours a week do you think?
On average, I'd say probably about a day, maybe a day and a half a week. It oscillated a little bit around, respiratory season, my school schedule, what they had going on. But I would say probably maybe like 10, 15 hours a week overall. But it definitely ebbed and flowed over the course of that year.
Gotcha. Okay. And then in hindsight, just because I think this could be helpful to people. In hindsight, when you're looking back at the work that you did and volunteer, obviously that was tremendously helpful for you and the experience you picked up. In hindsight, how helpful were you to the department?
No, that's a great question. So I think what we all struggle with having a volunteer and intern is what work can we have them do that is value added, that teaches them something. And so I think I was really fortunate to have some really amazing IPs. And the mentor at the time, her name was Esther Munoz. She was the lead at Phoenix Children's Hospital. And so what she did is she had me collect hand hygiene observations. So she taught me about hand hygiene. She taught me about standard and transmission-based isolation. She taught me about what PPE was required. And she really took the time to help me understand, if it's C. diff, the recommendation is soap and water. As a pediatric hospital, we had a NICU, we had hematology, BMT units, and how those patients needed to be treated or how we practice hand hygiene in those areas was different. And so she also asked me to collect data on different roles. So I would collect data on physicians, on nurses, but she asked me to look at visitors and family members. So she really asked me to look at hand hygiene at the time in a really novel way. And what she appreciated about me is I wasn't a healthcare worker. So I didn't have any of those innate biases or concerns about upsetting anybody because none of these people were in my department. They didn't know who I was. And I also was the perfect fly on the wall because, again, nobody knew who I was, but I worked at the hospital. So I was supposed to be there. And so they really found that secret shopper piece and what I brought to the table really, really helpful. And some of those observations led to policy changes. So, for example, visitors, we used to have a lot of celebrity visitors that came, and I observed that they didn't practice hand hygiene. So they were able to then work with that group to make sure that these celebrities that came in to visit these children were given education and training on how to perform hand hygiene and even how to handle some of those transmission-based isolation pieces. So I think it definitely was mutually beneficial. And then once I moved past hand hygiene, I was doing some of the skip measures. And so any IP will tell you that doing tedious chart extraction is not the favorite part of their job. And so I was confident enough to be able to pull this information out of the chart. And so I was able to do, again, some of this more tedious work. And I saved the department a lot of time and they were able to focus on other things.
That's awesome. I know a lot of the directors are thrilled to have any assistance they can. There's always something for somebody to do. But I've just been trying to force myself into somebody else's shoes and kind of what that conversation looks like to figure out where you could actually offer value. But I think those are two really good places and really insightful. So that'll be great. Okay. So you volunteered for a while, applied for a while, ultimately decided that you were going to have to look outside of Arizona. And that's another common trend that we've seen. The reality is there's just not that many positions for infection prevention. We're pushing for more of them, but right now there's not a ton. So often, if you're wanting to really advance your career, we've seen that you have to be willing to relocate if you want to do so quickly, unless things just kind of fall in line. So obviously you decided you were willing to do that. Was that a difficult decision for you?
It was. I would also say that I was really fortunate in that regard because my mentors at Phoenix Children's were willing to write recommendations for me. And so they were willing to kind of say, these are the things that she knows how to do. So I find kind of the biggest crux of getting into infection prevention is they want you to have, 1 to 2 years of experience, but you can't get 1 or 2 years of experience unless you have an opportunity to be in the department. So that,
Right.
that again opened a lot of doors for me. So I wasn't applying for these positions as a brand new novice IP. I was approaching these roles with having some level of experience. So there were things I was able to do independently, which I think was really truly a game changer for me. But as far as making the decision, yes, I was, halfway through my doctorate program. I was a single parent. I had 2 small children. And I was applying for positions in locations I had not been. I've never lived before. I didn't know anybody. I knew, having volunteered in the IP program, that when there was an outbreak or an exposure, that there could be a lot of long hours. And so how would that look, being a single parent in a new area and not having that support system?
Yeah. Okay. So what's interesting to me, you jump into infection prevention. You landed a job in Montclair, California. Now, is this you ended up as a manager of infection control and employee health? Is that correct?
Yes.
Okay. All right. So a couple of questions there. First, what was the scope of that? Like how big was that hospital? Were you by yourself? Give me the parameters of that position.
Yes, so it was a small community hospital. I believe they were 101 beds. I was a sole practitioner, and it's not atypical to have a sole practitioner have the title of a manager simply because you're the head of the program, because you are the program. So that piece wasn't atypical, and the hospital itself wasn't large enough to have a separate employee health and a separate IP manager. And so when I applied for that job, again, we had a lot of conversations about what I could and could not do within that role, because employee health generally is led by a nurse, and those nurses can actually practice, some of the actual employee health work with the staff. And I was exempt from doing that, or prohibited from doing that, because I didn't hold a nursing license.
Yeah, I was going to say, so, well, first, do you remember what the average daily census was?
It was super low. I want to say it was around 30 to 40.
Okay. Now, obviously we know this now as far as the different titles and whatnot. When you applied and just saw manager of infection prevention, do you remember, was that something you thought would be like a long shot, or did you understand that there were manager titles, smaller facilities? This is a reasonable position. Do you remember your thought?
Yeah, I think a little bit of both. So again, I was working with an IP program and an actual IP. So I had an existing network to say, hey, how best to apply, where to apply. So I had that, but I absolutely thought it was a long shot. And I will say, good, bad, or indifferent, taking risks and being brave is something that I have found serves me in both my personal and my professional life. And so, if you don't take a swing at something, you can't hit it. And the universe has a propensity of taking you wherever you need to go. And so throw it out there. And if it's meant to be, it'll happen. And if not, it won't. And so I really kind of approached that mentality with how I applied for jobs, not just then, but throughout my career.
That's great. That's great. So yeah, so you ended up with the manager position, which is an awesome first time title for sure. But this is being a sole preventionist. I mean, this is a lot for a first time official role. So obviously you've got, I mean, it's all you. And I would imagine there probably wasn't much infection prevention support there. I mean, in that first facility, was there anybody that really understood infection prevention that you could rely on, or were you having to go outside of the hospital for that?
Well, I was fortunate because it was part of a larger healthcare network. So Montclair Hospital was owned by Prime Healthcare. And so there were other IPs and other sites that I could connect with. And also, again, I kind of had my own blossoming IP network that I was able to go to with questions. And so even though I was, literally, right, a sole provider, I never felt that way. I always had, the phone a friend, email a friend, text a friend, call a friend, and really leverage those resources. So I knew going into this that I was going to be very driven by, guidelines and textbooks and a lot of reading. And I felt very comfortable in that space as a doctorate student. I mean, that's pretty much what we do. So I knew I had the core skill set in order to gain whatever knowledge I needed. And I'm naturally curious by nature. So I'm not one of those people who has to know the answer. I'm perfectly comfortable saying I don't know, but I'll figure it out. And if I couldn't figure it out on my own, or if I wasn't sure, then I would leverage my phone a friend and reach out to somebody who had more expertise, or even just run my thought process by them. So again, just really approaching it from a place of curiosity and humility, I think was really important for me. Not just then, but still now, I still approach my role from a place of humility and curiosity, because I still don't know all the answers, nor will I ever.
Yeah, no, it's great. And you mentioned you kind of didn't realize that a non-nurse could do this job. And then, but you saw somebody do it. So you kind of followed their kind of footsteps and learned from them. Um, I will say, just being in the recruiting space, there's obviously still a lot of health systems that demand a nurse. Um, there's definitely been more of a push for diverse backgrounds here lately, and I think it's trending in the right direction. But historically, that's been the case, and I'll say it's very much the case in smaller facilities and in sole preventionist positions like this one. Um, so obviously, you got the job, so you were able to um, sell yourself in the interview that a non-nurse was capable of this job. So 2 questions here. One, were you the first non-nurse at this hospital to do infection prevention? And then 2, when you got there, um, how long did you face any kind of flack for being a non-nurse from people in the hospital that were accustomed to seeing a nurse in that role?
Great question. So I ironically was not the first nurse. So the person who my predecessor was also a non-nurse. He actually was, he worked in TB control. So not quite a microbiologist, but microbiology adjacent. And he was
Okay.
involved in the hiring of his replacement. And so when he saw me, saw my background, saw my education, I think he saw that I had, again, some of those fundamental foundational pieces. And he thought I could be successful in the role. And yes, I definitely got slack for not being a clinician. I think there's still a lot of bias and prejudice around, providers having licenses versus non-licensure. But I will
Mm-hmm.
say that there are a lot of beautiful pros and cons. And so what I love about being a non-clinician is I don't have that bias. I don't have that lens. And so I'm really looking at things from a totally different perspective, which I think is really valuable. But also gives me such great respect for the people that do the frontline work. And so there's no competition there. Like, again, just really approaching it from a place of curiosity and really wanting to understand how they navigate that role, and how they do it, and really just being there and being present with it, I think is really important. And so I think really approaching that, each role I've had has been really, really important, because at the end of the day, people just want to feel seen, valued, and recognized. And so if you approach it like, hey, I want to know how you do that, or what is your experience like, people are really open to sharing, oh, this is how you put in a central line, or hey, we're going to be doing this really complicated case. Would you like to observe? So by developing those relationships and really creating a space where you can have shared knowledge and shared understanding, people will invite you in and they will allow you to be part of their world. And really, again, that part is so vital in being successful as an IP.
That's awesome. And now tell me, I want to hone in a little more on the non-nurse piece. Um, and this is something you experience in all of your jobs, I have no doubt. But how would you recommend, and then also how did you go about gaining the clinical knowledge that's necessary for an infection prevention role without being kind of an educated nurse?
Yeah, absolutely. So I think as far as what I recommend for others, and I've actually had people do this, reach out to others on LinkedIn or through their networks. And I actually have a beautiful story I'd love to share. So in
Yeah.
the fall of 2019, I was reached out. I received a LinkedIn request from a nice young lady named Hannah Batty. And I kind of ignored it at the time. But then my friend called me, another IP I'd worked with at another location. He's like, hey, I talked to this girl. Her name's Hannah. She really wants to be an IP. She reminds me so much of you. I really think you should talk to her. So I called Hannah and she's like, yeah, I really want to get into infection prevention. She had a master's degree in biological science. She was struggling to get in. And so she's like, well, can I meet with you? So I invited her to City of Hope, which is where I was working at the time. And she was passionate and knowledgeable and really excited about it. And so because of that experience, I went and talked to my leadership in my hospital about inviting her in as a volunteer. And so after a lot of conversation, we were able to get her in as a volunteer. So she started January 2020. And I imagine you can see where this conversation is going. So after a couple of months, we're starting COVID, right? And again, we're short staffed and all this is going on. And she's really just picking it up, excelling, loving the work. And we were able to leverage getting her a paid internship. So at the time, she went from being a volunteer to a paid intern. And then at the end of, kind of more fall 2020, we were able to open an IP role. And she was able to apply and actually accepted that role. So again, reaching out to people, that networking has been vital. And she said she actually messaged over 100 people trying to find somebody who would be willing to kind of help her in. But her tenacity and her passion not only really kind of connected with me, but connected with somebody else. And so that's what I would recommend, is be tenacious and keep connecting with people, because somebody will answer. And there may not be a volunteer program at the hospital where that person works, but they might know somebody where there is. And so that networking piece is huge. And then I forgot the second part of your question.
How did you go about learning the clinical experience that you needed in the role?
Thank you. So I think approaching things from a place of humility and really a place of curiosity and understanding was really important. So when I started off at Montclair, again, it was a smaller hospital, and I didn't even really know what a central line was or exactly how Foleys were inserted. And so really, taking the time, asking if I could shadow some of the nurses. I spent a lot of time in the ICU, just being there. And then once they felt comfortable with me and they were able to talk about, what their barriers are, what their challenges are, I was able to talk to them about how I do surveillance and what I'm looking for. So there's ended up being really creating this kind of shared understanding from each of our lenses about how our work intersected. And then once they felt comfortable with me, I got invited to, they'd call me if they were doing a PICC line insertion with an ultrasound, or I got invited to observe, cesarean section. I got invited into the ED to see how they did Foleys or how they handled, different types of cases. So again, networking, I think, is really important. Being human, asking really thoughtful questions, wanting to hear, how other people navigate their roles, creating that shared understanding, and really kind of sharing how each role, each lens really intersects and supports each other. And then again, they wanted me to understand what they were going through, because that better enabled me to support them. So I think, again, I've approached that at that role and every role since. And again, we're just people at the end of the day.
Yeah, no, it's excellent stuff. That's good stuff. And you stayed in this role, right, for a couple of years, and then it looks like you took a director job after that. So first director position. How did that come about, and what was that transition like?
So I want to predecess it by saying that I was in leadership for a couple years and I took a step back. And the reason why is my education really, made me, I think, more qualified or more appealing for leadership roles. But I didn't always have the experience or the confidence to be in that role. And so I felt pretty good after Montclair. I'd been there for a couple years. And then I was invited to apply for a director role, and it was over kind of one clear hospital. We supported a second hospital and supported a third. And this particular hospital was going through a lot of CMS. There's a lot of CMS visits, and kind of the level of understanding and the complexity of the problems that they were navigating was really outside of my skill set and my confidence. And so again, I was super fortunate that I had other amazing IPs to lean on, solicit their input, their advice. Anne-Marie Flood has been probably my biggest mentor and champion in an IP role. But there were just things there that were really outside of my scope that I didn't feel comfortable navigating. So from that role, I took a step back to a manager, and there I actually took a step back to just lead IP, really wanting to spend time and energy focusing on building that solid foundation, navigating some of those more complex cases so that I could provide really thoughtful, insightful responses versus just quoting something out of a textbook. Because what I learned about infection prevention is they teach it like anything else in kind of this black and white fashion. But the practice of infection prevention is every other color but black and white. And so how do you effectively, employ a risk assessment and really understanding what is the problem that you're trying to accomplish, and really what amount of effort or work needs to go into minimizing that risk. And that really does take years to cultivate and to feel comfortable with. And in a position of leadership or position of power, you really want to do so in a way that is best for the organization and makes you feel confident in that what you're saying is accurate and appropriate.
So did you, just make sure I understood it correctly, you took the director position, realized there's some more kind of staff level stuff that you needed to get covered, and then so you took is that when you transitioned to KP for a minute?
Mm-hmm.
Okay, and then from there to City of Hope as a senior infection preventionist. Now, is City of Hope, is that a cancer hospital?
Yes, it's the only freestanding comprehensive cancer center in all of California. And what I loved about it is the complexity of the work they do. So it's almost like infection prevention on steroids. And what I mean by that is you're really having to understand the pathophysiology. You're utilizing definitions you don't utilize really in other environments. And really the way you approach things is a lot more thoughtful and informed, because the population is at such at risk for infections.
Okay, so let me hone in on this a little bit, because one thing that's pretty unique about your background, now that I'm looking at it, you've worked academic, you've gone nonprofit, you've gone for-profit, you've gone cancer hospital, you've done children's hospital, you've done, I guess, your standard short-term acute care hospital. So you've been all over the map as far as the different types of facilities and whatnot. Can you just spend some time kind of talking about the differences? I mean, you can kind of fill us in how you want to, but I'm just curious as to the differences or like the surprises between the different facilities, or kind of which one you've decided I mean, not many people get to try out all the different things in their career. So if you could just provide some insight onto, like, I don't know, if you're this way, this type of facility might be particularly interesting, or this facility was particularly interesting to me because of this aspect. I'm just kind of curious the differences and just for context for me I mean, we typically just work short-term acute care hospitals. We've done some cancer centers and some different things, but from a recruiting perspective, I don't really know the difference in the day-to-day role at these different facilities. I know obviously at Children's Hospital, they're probably more receptive to contagious infections, and they're more vulnerable, I imagine. But anyway, just fill in some blanks there for me. How are these different, and kind of what's similar as well?
So I think that's a great question. So when you're a sole practitioner, a smaller organization, you wear all the hats. And so you're really truly a generalist. And there may be things that pop up, like an exposure, or for me at Montclair, we had a measles outbreak that started at Disneyland. And then we had Ebola that we were prepping for, where you have an opportunity to really specialize. But for the sole practitioner, you're again, a little bit of everything, but you don't get an opportunity to really specialize and dig deep. And so something that's been kind of a trending factor in my, professional life is I have this overarching understanding, and then I want to know more. I want to dig down into things. And so by working at different patient populations, you really get an ability to dig down in different ways. And then understandably, different patient populations have different risks. So for example, a pediatric hospital, there's a lot of concern around cohorting and respiratory season. And, children have different types of diseases and different types of infections than adults have. When you work at, predominantly an acute care hospital that's maybe more surgical, your length of stay is shorter. And so you're more focusing more on maybe surgical site infections and getting Foley's out. When you work at, organizations that have a higher acuity of patients, they're sicker. There's more comorbidities. And so again, how you approach that as an IP and how you dig deeper into that knowledge base just evolves. What I will say I loved most was cancer. And what I love most about cancer is really the pathophysiology, but also just how these patients could really have no immune system, and who got sick and who didn't, and maybe those factors why. So when you're dealing with a patient with a 0 white blood cell count, things like whether or not they perform CHG bathing, or whether or not people are washing their hands, or whether or not we used aseptic technique, I think has a lot more impact than when you have a patient who's immunocompetent. And so I think having, for me personally, being able to work in these different patient populations has really allowed me to really develop a really beautiful lens and see things again from that risk perspective. For people who want to specialize, I would definitely invite them to think about like how do they want to specialize, what are those areas of expertise, and then there is generally an organization that would support that. So pediatrics, might be more respiratory viruses, more about cohorting patients, more about navigating pathophysiology around really complicated surgeries or patients with this complex genetic disorders such as cystic fibrosis that maybe don't make it to adulthood. If you're looking at, again, kind of more of a general, smaller acute care hospital, you're going to get a chance to play with everything. But again, you may not have an opportunity to become more expert. And then again, cancer, you're really dealing with those HAI surveillance definitions and really these disease states that you just won't see anywhere else. But I will say what I think has been good for me is all those places that I've worked really led me to UCSF, where literally they do all the things that you talked about. We've got pediatrics, we've got cancer, we have a couple smaller sites, we have a couple larger sites. And so having worked where I've worked, how I've worked, I'm really able to approach my role, I think, in a more successful, kind of more well-rounded, more experienced fashion than I would maybe otherwise.
Yeah, no, that's excellent. Excellent. I want to make sure I have enough time to ask a couple questions about your current role. But when you were the manager of epidemiology at Scripps, you did that for almost 2 years, about a year and a half or so, it looks like. How big was that facility?
It's over 400 beds, and they were a level 1
Okay.
trauma center. And there was a couple of on-site medical offices as well.
Now, was that your first position where you managed a team?
No, my first position where I managed a team was actually back when I was a director over at Southern California Hospitals, which was my second IP job.
Gotcha. Okay. And then you made a big jump then from the manager of epidemiology at Scripps up to the system director at UCSF.
Yes, I did.
So system director, and you obviously have said a few things that you're more of a hands-on kind of worker bee as far as how you think of yourself and what you enjoy doing. So how was that transition like? Because you go from a manager, which I imagine allows for more hands-on work, to more kind of a corporate level position. So what was that transition like? And are you enjoying that role?
Yeah, that's a great question. So I love this story because my very first day at UCSF was the first day of our Joint Commission survey. And so it was kind of like the perfect way to start. I will say that I really do enjoy the position. And again, I love to learn. I'm a naturally curious person. And the IPs that work at UCSF are brilliant. They're passionate. They're talented. And their level of knowledge and expertise is significantly more than my own. And so I've always loved surrounding myself by people who, know more, who I can learn from, who I can teach. And so that part has been beautiful. Also, it's a time of great transition. It's just like everywhere else in healthcare. And so having had the background that I've had working in the places that I have, I think, again, it gives me a more balanced lens. And so, yes, there are things that we need to work on. There's quality improvements, but how do we do that in a way where we're co-creating it with our stakeholders? What is that middle ground? And so I think that I really have enjoyed it, and working with just brilliant, passionate, like just truly like just remarkable people. And the work that's done at UCSF is extraordinary. Some of the surgeries, the patients, the outcomes, the work we do, and then just the way it serves San Francisco. So UCSF is the second largest employer after the city of San Francisco by itself.
Wow.
So it has a huge blueprint. And also, again, I love kind of connecting people. I love, helping people feel their passions and pursue things they're interested in. And so I really saw, as a system director, the ability to kind of create that vision for the program and help, these, again, beautifully like talented, passionate, highly educated individuals, continue to pursue the things that bring them joy. Because I've done it. I've been in, field IP. I've gone through the ranks. And so, again, I think I have a different lens and experience and such a great appreciation and gratitude for the people that do the work.
Yeah. And was this your first academic hospital?
It was. I mean, the Scripps did do some training and education, but it was not anything like UCSF.
Okay. How what does the academic piece add? Obviously, when we search for academic hospitals, all of them kind of say that there's just a certain type of person that's made for the academic environment. Now that you're there and kind of have experienced it for over a year now, how would you describe that culture compared to some of the other places you were?
That's a great question. So I think what I love most about the academic is they are the people doing the work that gets published that other people follow. And so, but we're not doing it in an uninformed kind of way. So we have this ability to work with, again, highly educated, highly trained, highly expert people. And there's this willingness to try new pilots or try new products or try new approaches. And so we're creating the literature, creating the work, the path that other people follow. And so as an IP, I think it really requires you to be highly flexible, highly adaptable, have a good core knowledge, and really be open to failing. Be willing to try something and have it not work, or be asked a question you don't know the answer to. I'm regularly emailed questions I have no answer to. And so again, reaching out to my IPs or reaching out to my network to answer those questions. And so again, it really just marries everything together, but really requires, I think, a little bit of fearlessness.
Great. And you've mentioned humility a lot as far as being a kind of an approach to really anything, but in particular this profession. Is that like a culture you've tried to instill where you are, or like when it comes to your department's culture, I guess, what have you tried to kind of put at the forefront of that?
That's a great question. So absolutely humility, approaching things from a place of curiosity, checking for understanding, but also, how do we co-create, whether it be an action plan, how do we co-create, kind of the next steps, how do we create that shared understanding? And a beautiful thing, at UCSF and even at other organizations I've worked at is, I get a lot of really highly trained, highly educated individuals. And so we're all experts in our own right. And so how do you take a table full of experts, right, who have experts in their own subject matter, get them at a table and come to a consensus? Or how do you decide what our path's going to be moving forward? And so what I love for my team is, again, kind of having them really focus on that subject matter expertise, moving them away from work that maybe doesn't need to be done by our team, and really allowing them to grow and stretch in ways that bring them joy.
And I know something, I just remember having a conversation previously, or maybe it was through Johnny and me just overhearing it. But when you go to form a team, I believe I remember you saying that you just really value a diverse background and experience with different things. So can you kind of lean into that philosophy a little bit and just explain, I guess, why you got there and why that's beneficial?
Yeah, absolutely. I believe that I had an atypical background, and I have found that, I bring a unique lens that has value. And having worked with all of these, again, amazing stakeholders and partners, during my career, they all bring a level of expertise and a lens that we don't have. And so the best way, I think, to really look at things from a risk assessment, really look at things from a really balanced way, is to bring in other perspectives, other experiences into the mix. And that, I think, helps kind of avoid, I don't want to call them maybe blind spots, but I do think that if you just hire a bunch of people just like you with the same expertise, same background, same lens, you're missing something really vital there. And so I would say that my best hire that I ever made was a nursing informaticist. And in retrospect, it is a natural marriage, and I don't know why we don't have more nursing informaticists in infection prevention. But what it brought to the table is, we have this, again, IP lens, but we don't necessarily have the ability or the training to provide that information in a way that nursing really understands and needs it. So having somebody who has the expertise around, performance improvement, maybe they're, black belt, or they have some of this other types of training, is it allows us to take that core expertise or recommendations that we have, but also package it and present it in a way that our audience needs. And so I think it really, again, bringing that extra lens has been vital. Also, none of us are perfect. Like, we all have, ways for us to grow and stretch in new ways. And so by adding other other staff from other disciplines, you're again bringing that expertise to the table that you would not otherwise benefit from.
Wow, that's a great answer. I want to recognize this because you're one of only a handful of CICs that have a PhD. So you went in early about your philosophy for like getting it, which makes a lot of sense. Now that you have it, is this something you would recommend other infection preventionists do? And I guess why? Or do you feel like now it could be a give or take thing?
That's a great question. I think ultimately it depends on what the career ambitions of the person are. So for me, I've always seen myself leaning ultimately back into academia. So right now I'm very much interested in the graduate level and undergraduate programs that they're building for IPs. And so I see my next chapter as really teaching those classes, really leaning more into the academic side. I'm also really big into research. So I like to do research. I like to write articles. I like to publish. And so doing the PhD was just a very natural extension of how I saw myself progressing professionally, and also really supported my other interests. That may not be, again, the appropriate or the best decision for somebody else. I also recognize that in leadership and even in the hospital environment, if you're not a physician, maybe your level of expertise or, how you're seen may not have the gravitas as it does if you have a higher level of education. So I can say, I think it's unfortunate, but I can say that having a doctorate degree does afford me, I think, a level of gravitas or a level of credentials where people are maybe more open to hearing my recommendations than they are maybe somebody who doesn't. And again, I think that's unfortunate because there are many IPs that don't have doctorates that are way more experienced and more brilliant and more knowledgeable than I am. But I think I also just recognized that going into it. And again, for me, I didn't want to have any glass ceilings.
Yeah, that's great. And then the last question, that's a little bit off topic, but it's something that we've been tossing around in the office. So I'd love to hear your insight on this. But if you were to go full on into work mode right now and somebody asked you to make a financial case for infection prevention and the impact it could have, what would your talking points be?
So ironically, I've done that. So my talking points would be, I actually worked with Dr. Knighton, who was the executive director at APEC. So she came to UCSF in the fall. And I'm also familiar with Rebecca Bottle's work with both APEC and SHE to create some staffing models. So I actually was able to connect with both of them while I was putting my business case together to kind of get a sense of what their thought process was or how they were going to encapsulate it. I also am part of the UC system. So I had the good fortune of being able to reach out to all of the other, hype directors at all the other UCs. So I really did my research in advance. And then I have found just, again, through my career, that you need to present a proposal for your audience. And so in this case, my audience is my leadership. So what does my leadership at UCSF value most? And then how do I provide that argument in a way that makes sense to them, that really touches on the pieces that are most impactful? And so I leveraged my network inside my facility, talked to some of my senior leadership, got some good ideas, really thought about who I was presenting this case to. And I came up with a short PowerPoint presentation because I love PowerPoint. But I also came up with a really thoughtful, comprehensive, 6-page proposal that I submitted for review.
Awesome. That's great. All right. So I think we've covered everything that I wanted to talk on. Do you have anything any soundbite or whatever that you just want out there, or anything that you want to say to young IPs, or anything you just kind of want to close?
Yeah, actually I do. I'd like to talk a little bit about coaching. When I was, during COVID in 2020, I really experienced just how burnt out everybody was and how emotionally drained people were. And unfortunately, during COVID, we still had to have crucial conversations with our partners. And I found sometimes even saying hi to somebody would put them in tears. And so I was really aware of how vital having the right approach and being empathetic and compassionate when trying to have some of these challenging conversations with my partners were. And I felt really ill-equipped. And so I reached out to my network and said, how can I maybe improve my skill set on this or get some more tools in? Because I don't want anyone to have a conversation with me and feel upset or that I wasn't there to support them. And so, this whole idea of coaching kind of came out of it. So I actually pursued a graduate certification program for evidence-based coaching, and learned how to be a professional coach. And I went and
Wow.
got certified. So I'm also, I think, the only CIC who actually is a certified coach as well. And that has been really important and vital to me because as IPs, we have so many crucial conversations with all walks of life. So we can go from talking to an EVS worker, about hand hygiene to a meeting, with our CEO talking about how do we improve staffing for our departments. And very few of us, whether it be through our, official, formal or informal, education training, are really provided any support or guidance or tools and how to really, approach things from that coaching methodology. And so what I've been looking at doing, aside from teaching, is also really bringing this idea of coaching into the curriculum, into the training of IPs so that they can get some actual support and tools and how to have these challenging conversations. And what I think is really important about that is not even just getting people into the role, but keeping people in the role. So when I've talked to, people who have left the infection prevention role over the last 10 years, one of the key things that I hear them saying is that they don't feel valued. They feel like they're giving recommendations. These are deficiencies. Why are they not being resolved? And when talking to our partners about how they view infection preventionists, they see us as police. And so how do we switch that narrative? How do we again create the space where we're co-creating action items, we're co-creating a shared understanding, and people want us in their department. They want us to come in and put our IP lens in. And then how do we take those, opportunities, those deficiencies, and help that department leverage those to get more staffing or more support or whatever it is that they need. So I'd really love to see this idea of coaching not only be included in the curriculum of the IP programs, but also really be talked about and how do we train people through a coaching lens. And then after I finished my program, I created my own company called Innovative Partner Institute. And I actually have been doing coaching of IPs and other people's in leadership because we don't have coaches that we can go to. So in our professional world, if you are in a position of leadership, sometimes they'll let you or support you seeing a coach. But for sole practitioners or people who are not in leadership positions, they don't have access to those kind of resources. And having somebody that you walk through, how do I have this conversation or how do I navigate this really challenging situation, not even from a content or knowledge perspective, but just from a human to human perspective, I think is really vital. And I think it's a piece that's still very much missing and needed in the infection prevention world.
No, that's very cool, and that's pretty in line with kind of how we've been thinking too. So we may need to connect when it comes to this coaching piece and see if there's a way to really promote that and push that through, because it's a common thing that people have asked for and want. So I think you're right on the nose there. One follow up to what you kind of were just talking about. You've referred to this network of IPs that you've built. What does that practically look like? Is that just like a group text, or is it just like people you can email and get a response from, or is this more like a local APIC chapter or a private Facebook group, or like what is it kind of more tangibly?
So what it looks like for me is I think a little bit of what you said. So I do have a group chat with all the other UC directors. I also have, again, group chats with other people, other IPs in different parts of the country. I'm fortunate that I'm part of the editorial panel for the prevention strategist. So that's a network. I also am part of the professional development committee, which is also a network. I'm also the education director for my local APEC chapter, which is also a network. And then I find people on LinkedIn that I resonate with or who I think are amazing, and I connect with them and I'll ask them questions or ask if they have time to connect. So always looking to connect with people that, again, are really passionate about the field, or I think they can help them or they think they can help me. And I've also been fortunate enough that I've been able to mentor some IPs that are looking to sit for their CIC. So I've been able to provide them coaching and again, play it forward.
Wow. Okay, you just threw a lot of stuff out in that answer that I was not aware of and we haven't touched on. How in the world do you have time for all this stuff? You've talked about volunteering along with a full-time job. You've talked about pursuing a PhD while you're doing it. You've now have mentioned like 6 associations you're dealing with while being a system director in an academic hospital that's the second largest employer of the state. What in the world? How do you make time for all of it, and how do you avoid burnout?
So those pieces, the coaching, the academics, the being involved in these different committees, reviewing articles, writing articles, those things nourish me. And so that's where I think I fill my cup. I also, don't need to watch every new TV show or every new movie that's out. And so I would rather connect in different ways and ways that, again, that fuel me and nourish me. And so that's really an active decision I've made. And then for me, like I'm about ready to transition out of working at a hospital, right? And really looking at maybe doing something on my own. So I'm in kind of the precipice of making that
Gotcha.
transition out of the hospital as assistant director and really, how do I lean into that teaching and that coaching piece maybe on my own?
Yeah, very cool. Yeah, we mentioned it earlier, but that's commonality. You guys just don't seem to have the 24-hour day that everybody else has. So I'm just kidding. Trying to wrap my head around it.
Thank you for joining us on this episode of Voice for Infection Prevention. We hope you found our discussions informative and insightful. Remember to subscribe to our podcast for more conversations with experts in the field, and don't forget to leave us a review to let us know what you think. For additional resources and to stay updated on the latest news in infection prevention, visit our website at voiceforip.com. Thank you again for listening. Until next time, stay safe and continue your commitment to excellence in infection prevention.